Good morning once again. Like I said last week that we're going to do the face abnormalities this week. We postponed last week's meeting following the death of the unfortunate death of one of our colleagues' mother, Mr. Sanga. May he so rest in peace. We managed to accompany the family to the burial place in Rewa, and everything went on well. So yeah, so the face abnormalities probably I thought it is better that we just go through physiology to just bring a little bit of understanding of what will be going on during the face formation. Then I think this will help in terms of understanding why we do certain views when we do the scans, and also it will help and explain to the parents some of the abnormalities that we do encounter during the scanning for abnormalities. So I've summarized what takes place during the embryogenesis period, the embryogenesis or morphogenesis period. The morphogenesis period normally takes place after the 3rd week, from the end of the 3rd week to the 8th week. We're talking of from conception. So whenever we are referencing the last normal menstrual period, we are probably talking of between the 5th and the 10th week from the last normal menstrual period. It is very important for all of us to understand that between the 5th and 10th week, that's where most of the baby's organs are formed. Of course, there are some which continue to form later, but most of the organs are actually formed and defined between this 5th and the 10th week. Most women, they realize that they are pregnant probably in their 7th to the 8th week after LMP, because some will be thinking probably just a delayed period. It's not common for women to know around 5 weeks that they are pregnant. Most of them, they won't. So why is this information important? It is important to know that when it comes to fetal abnormalities, if teratogenic substances are taken, in most cases, by the time the woman realizes that they are pregnant, the insult probably might have happened. So we need to know this. This is why even with the folic acid, we highly recommend that women should take it preconceptionally, because if we ask women to do it when they find out that they are pregnant, unfortunately, it will be too late for most of the women when they find out that they are pregnant, because the baby will be formed by the time they are 3 months, and most of the organs are already defined in terms of what they are going to be. So this is how it starts. After, of course, the gastroenterology relation, which I'm not going to bother you with, the process which takes place between the conception and the 3rd week, the end of the 3rd week of conception, we start here, where in terms of the face, we have something called the frontal nasal prominence. This is what you can see here. That's the frontal nasal prominence. Then just below it, we do have the maxillary process on the sides, and then we have the oral cavity. Some books will call it the stomodium. The stomodium. So, and below it, we also have the mandibular process. That's the mandibular process here. So it is these 5 structures that form the face. So we have the frontal nasal prominence, then we have the 2 maxillary processes, and then the oral cavity and the mandibular process. So these 5 structures are responsible for forming the face. The question is, how do they differentiate to form the face? What will happen is that the frontal nasal prominence, this one, will differentiate to give us the medial nasal processes, and will also differentiate to give us the lateral nasal processes and the nasal pits, and in addition, the future eyes here. So it is this differentiation that begins to form the organs. Then as for the oral cavity, for the medium, for the maxillary processes, what then happens through the differentiation is that these organs will migrate towards the midline, will fuse towards the midline. When they do fuse, the nasal processes will fuse on the midline and form a number of structures, which I will be describing to you now. And the lateral nasal processes are the ones that form the bulk of our nose, of the nose. The bulk of the nose here is formed by the nasal process, but the medial nasal process, they fuse towards the center, they migrate towards the center and fuse. The same thing happens with the maxilla. The maxilla fuse towards the center, they meet somewhere in the midline, the two maxillary processes. The mandibular just differentiates, it's already fused in the early formation. This is why the cleft of the lower lip are not common. I have not come across it, because from the beginning, it's already fused. But these two have to fuse toward the center. It is these two, the medial nasal process and the maxilla, that form the central structures. And what are the central structures? The central structures vary from the tip of the nose here, and they also form the primary palate, this triangular shaped structure, and they form the upper lip. So failure to fuse in the midline of either the medial plate or the mandibles will result in the cleft forming, whether it is a cleft lip or a cleft palate. The medial process is the one that forms the primary palate here. So failure of fusion of the medial plate will normally result in the cleft palate. The fulcrum is this part of the nose here, is also formed by the medial process. So during the formation of the cleft palate, it could be either complete or incomplete. If it is incomplete, we may just have a cleft lip alone without a cleft palate. But if the failure to fuse is complete, then you are going to have a cleft palate and a cleft lip. Then the mandibles, what do the mandibles contribute when it comes to the palate? The mandibles, they're not just outside, but they're also growing inside the baby's mouth. And the two lateral shelves here of the mandibles fuse underneath the maxilla to form the secondary palate shelves. It is this secondary palate shelf that fuse at the center, and they will also fuse with the primary palate to form the complete palate. So there is a division of this anterior and the posterior palate here from the embryological formation of these organs. So whenever we are talking of palates, we're saying there's failure of migration and the failure of fusion of either the maxilla or the medial nasal process. So I hope I've explained it clearly there. Okay, probably there's also the issue of the nasal septum, which drops from the center. The nasal septum originates on its own on the roof of the mouth, and then it drops at the center, and the lung is the tongue. This is the tongue here. Also has to drop to the floor to allow the fusion of the palate. If there is failure of the tongue to drop to the roof of the floor, we're going to have a cleft palate on the secondary palate here. So during ultrasound, the most commonest palatal defects we are going to easily pick are the ones that are going to involve the primary palate rather than the secondary palate. If the secondary palate is involved on its own, it is extremely difficult to pick these cleft palates. This just to illustrate again, you can see there, that's the hard palate. And as you can see that the primary palate contribute to these four teeth as well, to the gum of these four teeth, while the rest is contributed by the secondary palate. So whenever we have a primary palate, this affects these teeth here. So the most common defects we screen for are primary palate defects with our imaging, as you will see on the image. Then of course you have the secondary palate, then you have the soft palate at the back here and the uvula. All these can be affected by palatal defects, but we know with the ultrasound it is extremely difficult to pick up these ones. All right, this is just the side view to just illustrate how things look in the middle. That's the hard palate there. This is the nasal cavity and the cavity and the soft palate at the back and the nasopharyngeal area. Then with ultrasound, how do we examine for the face? We use the profile view. This is the profile view. On the profile view, we look at the forehead to make sure that there's no flat forehead, there's no frontal bossing. And you also want to make sure that this ridge here is not showing an acute angle. At the ridge, the nasal ridge between the nose bone and the forehead, they should not be an acute angle here at this area. And the tip of the nose and the nasal bone, the upper lip, lower lip, and the chin. The line you draw from the forehead to the chin should be almost horizontal if the baby is perfectly in horizontal plane. Yeah. So that's a way to rule out micrognathia or retrognathism, because these are all facial defects. Then we do have the orbits. The orbits, we should make sure that there's another orbit which can be fitted in here for you to say the orbits are normal. And the palate, so this is the, when we are doing this examination, we are covering both the primary and the secondary palate, as you saw from the other diagram. This part here represents the primary palate, because this is where the four incisor teeth will develop. Then of course the rest. Most of the defects find them here, but you can also find them on the secondary palate, by the way, although they are rare. Then this is how we examine for the lips. So we check the upper lip. The particular focus here is the upper lip. It's very rare to get lower lip defects. So the upper lip you can see here. Then you also check the part of the filtrum. It's not easy to see, but what you see here is the nasal bridge. But the filtrum should also be examined and the nasal piece there. Okay, 3D helps us to see the face, as you can see. Then this is a render 3D. This is in grayscale, and this is in color, rendering of the face to try and check the face if you have any doubt as to how the face is forming. So, all right. Now, the other defect which we have to know of is the anophthalmia. Anophthalmia is total absence of the eye. But in most cases, you may encounter is more of a microphthalmia kind of situation. It took place in about 1 in 20,000 cases. The size of the eyeball is so small in microphthalmia, and the eyes are very tiny. Both of them may be there, or there could be one in a case of cyclopia, like one of our case here. I think this was a case of holoprosencephaly. In anophthalmia, we once met one case at Paris of anophthalmia. There was total absence of the eyeball and optic chiasma. This condition is like a violet that they can be both sides or one side, unilateral or bilateral. Chromosomal defects are found in about 50% of cases, more than 50%, mainly trisomy 13. This condition normally exists with holoprosencephaly, the mid-facial defects. As you are aware that holoprosencephaly, 1 in 2 babies with holoprosencephaly is trisomy 13, Patau syndrome. You can also encounter genetic syndromes in more than 50% of the cases. The most common are Gardner syndrome, where you have sporadic anophthalmia, ear defects, facial cleft, and facial macrosomia. We also have Fraser syndrome, which is an autosomal recessive, where there is micrognathia, facial cleft, tracheal atresia, bilateral renal genesis, defect, syndactyly or polydactyly. Then Fringe syndrome is an autosomal recessive again, and we have anophthalmia, facial cleft, micrognathia, ventriculomegaly, and diaphragmatic hernia. Again, like we have already said that whenever you pick one defect, don't walk away or close the shop and say we pick this defect. You need to look for associations to perform what you call the syndromic pattern approach to the defects. So you need to look for other defects so that you can be certain that indeed there is there is no other defect there. So in terms of diagnosis, ultrasound scan examination is key here, including neurosonography, and invasive testing for karyotype and array is an option, is a viable option, and the fetal brain MRI for diagnosis of abnormalities such as the absence of the optic nerve is also a diagnostic procedure required here. This is another case which just shows you anophthalmia, where we didn't find the orbits on this baby who had holoprosencephaly. You can see that there is a monoventricle there. So these cases do okay. In terms of follow-up, it's just standard care. However, if you are dealing with lethal conditions such as holoprosencephaly or a total absence of the eyes, offering termination of pregnancy is a viable option here. Then care delivery, standard obstetric care is recommended. If it is just isolated and unilateral, micrognathia or anophthalmia, the prognosis is good. But if it is part of the syndrome, then it is very bad. There is no increased risk of recurrence, except in cases where there is trisomy, then the recurrence risk is 1%. If it is due to those syndromes I have mentioned, which are all autosomal recessive, then the recurrence is 25% or 1 in 4. So remember, if we say autosomal recessive, the recurrence risk is about 1 in 4. Dacrocystocele. Sometimes you may want to image the eyes with the kind of imaging which I showed you, the planes which I showed you, and you see that besides the orbits, there are other structures. There's another structure which probably I didn't mention very well, which is formed from the middle. It should be formed from the middle nasal prominence, which is the lacrimal duct. The lacrimal duct, what it does is the one that allows the tears to be cleaned from your eye and sort of dumped into your mouth through the lacrimal duct. Where the lacrimal duct comes from the corner of the eye and it goes all the way to the back of your mouth. So it's the one that allows your tears to be cleaned. It's not all tears that you have that run down your tears, your cheeks. Some of them go through the lacrimal duct. So the dacrocystocele is normally a swelling of the lacrimal duct system, probably due to the obstruction or blockage, or due to the delayed canalization of the lacrimal duct. Normally should be canalized by 32 weeks, but if it goes beyond 32 weeks, then it will swell due to the accumulation of the secretion. Each occurs in about 1 in 4,000 births, and each occurs unilaterally in about 75% and 25% bilateral, and this is where it is located. Yeah, these are the orbits, and these are the lacrimal ducts which are swollen there. And In terms of the differential diagnosis, they can include anterior encephalocele, but normally encephalocele associated with abnormalities in the brain, such as hydrocephalus or ventriculomegaly. Hemangiomas are also differential diagnoses, but these are usually solid or remote subtated. And the dermoid cysts, again, these are normally superolateral, not anterolateral. So superior anterior there, not superolateral. So this is where the lacrimal ducts are. Standard obstetric care and delivery is recommended. They resolve spontaneously in the third trimester or within the first 3 months of life. Sometimes probing may be required to open the obstruction after birth, and there is no increase in risk of recurrence. Chromosome abnormalities, low association, investigation, just a detailed ultrasound scan is good enough, and the follow-up should be standard. So they soap resolve in most of the cases. There's another condition called epignathus. Epignathus occurs in about 1 in 200,000 births. So it is very rare. Probably that is why we have not seen it in our units at the moment. But what you are going to see is a tumor, a solid tumor, which is arising from the sphenoid bone, hard palate, and so also soft palate, the pharynx and the tongue and the jaw. So this is basically a tumor of the mouth. It will grow into the oral cavity and the nasal cavity and also intracranially. The differential diagnosis, of course, include the teratomas, the encephalocysts, and other tumors of the facial structure. One of the presentations is polyardermal due to the obstruction of the mouth. Due to pharyngeal compression, the baby is not able to swallow. So these are the tumor will look like. It's a scary tumor drawn here from the FMF website. So you can see that's the tumor, the epignathus. Associated with chromosomal abnormalities is very low. Neurosonography has to be done as part of the investigation. Follow-up every 4 weeks to monitor growth of the tumor and also associated fluid. Of course, if polyardermness, monitoring of cervical length has to be done, and amniotic drainage is an option to the couple. Fetal MRI to assess the brain extension of the tumor. Delivery, hospital with intensive care and pediatric surgery, around 38 weeks is the time for delivery, and cesarean section with the exit procedure is the desired management plan. So prognosis depends on the size of the lesion and the involvement of vital structures. Polyardermness is associated with poor prognosis, and the major cause of neonatal death is asphyxia due to air obstruction. Surgical resection with normal postoperative course is possible, and there's no increased risk of recurrence. Cataracts, they occur at 1 in 10,000. They could be unilateral or bilateral opacity of the lens. Bilateral lesions are usually syndromic, whereas unilateral usually related to fetal infection, the torch group. Let me just go back to the slide of the right. So which one are the eye lenses here? These ones are the eye lenses here. You see these round structures within the eye? These are the eye lenses. So when you are looking for cataracts, you are looking for opacification of the eye lenses. If the lenses are also opaque, so normally you may see opacification of the eye lenses because it is echogenic lenses. But if you see opacification in one of them or both of them, the eye lenses, then that's a cataract. So cataracts. All right, let's go back to our talk there. So the incidence of chromosome abnormalities is not increased. However, there are some genetic syndromes that are associated with this in about 10% of the cases. There's Walker-Warburg, which is autosomal recessive, which will present type 2 lissencephaly. Lissencephaly, that we said, is failure of brain neuronal migration with direction, the sulcation pattern fails to happen. Then also agenesis of the corpus callosum, then cerebral malformation and cataract, and chondrodysplasia punctata, where it's an X-linked recessive. We have a cataract, symmetric rhizomelic shortening, and epiphyseal calcifications. Then also congenital infections, where we have rubella, toxoplasmosis, CMV, which occurs in about 30% of the cases. So whenever we have cataracts, let's remember that we need to order a torch. Neurosonography is recommended, and invasive testing for karyotyping and arrays, CGH array, can be offered here, and also a torch screening for infection, torch test for infection. Standard follow-up is recommended. Then if infection is suspected, follow-up every 2 weeks. Standard obstetric care, and in isolated cases, the prognosis is good. However, ophthalmic intervention is required. Ophthalmologic intervention is required so that they can remove the cataract and probably deal with the vision issues. Whenever there is a syndrome, the prognosis is very poor. Risk of recurrence, if part of a syndrome, is about 25%, because those syndromes are autosomal recessive in inheritance pattern. Facial cleft. It occurs about in 1 in 700 deaths, and it's more common in males than females, and in whites than in blacks. This appears to this pertains to facial the cleft lip. If it is a cleft palate, then it is more common in females than males. So if you see a cleft palate, it is more common in males, in females than males, but the cleft lip is more common in boys. It occurs in 50% of the cases. In 50% of the cases, both lips and palate are affected. However, in 25% on the lip, and in 25%, it is just the palate. So if you see normal lips, it doesn't mean that the palate is abnormal. The image of checking for the cleft palate or for cleft palate still has to be done. It is unilateral in about 75% of the cases, and more common on the left side, and bilateral in about 25%. So this is an example of a cleft palate. A very big gap you see there. Because you can see there's non-continuity of the palate. I've already shown you images of how a palate looks. So there's non-continuity here. So you can see that it's involving both the primary and the secondary palate, because it's going from the midline all the way to the side here. So this was one of our cleft palate. This is an image of the cleft lip. So you can see we're trying to just do the same image of checking the lips. You can see there is a gap here on the upper lip. That's a cleft lip. We can see. So in terms of the ultrasound scan diagnosis, the typical cleft lip appears as a linear defect extending from one side of the lip to the lip into the nostril. You can see the extension to the nostril here on this side. This was the what? Was it the left or right-sided cleft lip? I can't remember, but it was unilateral. Cleft palate associated cleft lip may extend through the alveolar ridge and hard palate, reaching the floor of the nasal cavity or even the floor of the orbit. This is from the embryology sheet described there, that sometimes they do extend and they become very ugly, and sometimes they do expose the lacrimal duct as well. Both transverse and coronal planes are necessary for the diagnosis. I've already shown you the images when I started. Color Doppler may be useful to demonstrate flow across the palate in the case of cleft palate. Diagnosis of isolated cleft palate is difficult. Yes, it is. And diagnosis of cleft lip and palate at 11 to 13 weeks can be achieved by targeted examination of the retronasal triangle in a coronal view and the maxillary gap in the standard mid-center view of the face used in the routine annual screening. I did not put the image of the first trimester, but I think most of you have worked as in the first trimester clinic, where we produce the images of the retronasal triangle. Sometimes if the baby is, if you are lucky and you're around 13 weeks, you can actually see the palate like the way you see it on, in second trimester. It's extremely difficult to diagnose small palate. This is for big palates, what we are referring to here. So please don't think you can easily diagnose cleft palate. The cleft lip is almost impossible to diagnose in first trimester if it is isolated. Follow-up should be standard. Prenatal consultation with multidisciplinary team is mandatory. What it means is that we should consult the multidisciplinary team concerning the defect so that we plan and the parents are counseled adequately. Standard obstetric care and delivery. So in terms of the prognosis, it depends on the presence and type of associated anomalies. However, for isolated cases, the prognosis is very good with normal survival and corrective surgery. Surgery is normally done between the 3rd to the 6th month of age. The long-term issues in children with cleft lip and palate include dental abnormalities, hearing and olfactory problems, mid-facial hypoplasia, and psychological problems. About 25% of them have speech abnormalities requiring secondary palate surgery and speech therapy. Dental anomalies include missing or extra or malposition teeth, and they require braces on their permanent teeth. Most children have hearing abnormalities and may require myrigotomy with the placement of bilateral tympanotomy tubes to improve hearing. Regular psychological screening is recommended to assess the child's cognitive development, behavior, and self-image. This information, you may wonder, why do you need it? You need it to counsel the expecting couple. They should be aware that the cleft lip and palate will come with these packages. Because the parents should not be shocked when they discover that their child may have speech problems, may have some psychological problems, may have hearing problems. All this has to be told to the expecting couple, including that their teeth will be missing. As you saw that the first 4 teeth are contributed by the medial facial nasal prominence, and these very big clefts, they may all be missing those midline teeth. So recurrence risk, it is 5% if one of the sibling or parent is affected, and 10% if 2 siblings are affected. So couples who have had a baby with cleft lip, they should be seen in the fetal medicine into screening for facial defects of the face. If no fetal medicine, then somebody who knows how to check the face should properly check the baby's face, make sure they are okay. In terms, in syndromic cases, in terms of recurrence, of course, it varies in the forms of inheritance. If it is autosomal dominant, autosomal recessive, or X-linked or X-linked dominant or recessive, that determines the inheritance pattern. As you are aware that autosomal recessive is about 25%. Associated abnormalities include trisomy 13 and 18 are the commonest ones, and this occurs in about 1 to 2% of the cases. unilateral cleft is normally unassociated with with chromosome abnormalities. However, cleft lip also come with of syndromes, and it is said there are more than 400 syndromes which could occur in about 30% of the cases of the cleft lip and palate. The most commonest ones are Goldena syndrome, which is sporadic and with anophthalmia, ear defects, facial defects, and facial macrosomia. Then there is the Treacher-Collins syndrome, which is autosomal recessive or autosomal dominant with 60% de novo mutations. And we have hypoplasia of the maxilla and zygomatic bone. Then micrognathia, cleft palate, malformed or absent ears. Then we have Pierre-Robin anomaly, which comes with micrognathia, retrognathia, and cleft palate and glossotosis. So the Pierre-Robin, probably of all these ones, or probably the most common ones we may encounter. Yeah. So detailed ultrasound scan examination and karyotyping with both conventional karyotype and chromosome microarray should be offered. Then deliveries follow obstetric guidance, because there's no special delivery plans for cleft lip and palate, unless of course if it is gross and you worry about the breathing issues after birth, then in that case they have to be delivered at a center with pediatric surgical unit. But most cleft lip and palate, they are not done immediate surgery after birth, so there's no need to transfer them from Chukwembezi to Harare. If you have a cleft lip and palate, they should probably deliver in Mashingo, probably for immediate care, but the surgery is not done immediately. Hypertelorism. Hypertelorism occurs in about 1 in 20,000. This is an increase in the orbital diameter, which is greater than the 95th center. There are nomograms for interorbital diameters. These nomograms are available. I think they should be there in the Voluson. The nomograms for the interorbital diameter. There are associations. We may see this with trisomy 13, and we may also see this in other genetic syndrome, which occur in about 50% or more than 50% of the cases. The most common ones are frontal nasal dysplasia, which is again a sporadic occurrence, which is accompanied with hypertelorism, mid-facial cleft, abnormalities of the nose, cranial bifida occultum, and craniosynostosis. Craniosynostosis is the early fusion of the brain's sutures. And in this condition, we have Appert, Carpenter, Cruzon, and new Laxova syndrome. This is the new Laxova syndrome is an autosomal recessive that has got hypertelorism, microphthalmia, microcephaly, agenesis of the corpus callosum, contractures in the upper and lower limbs, and fetal growth restriction. Then the associated defects, this could be associated with frontal encephalocele and agenesis of the corpus callosum. So ultrasound scan examination is required, detailed ultrasound scan exam, and also invasive testing for karyotyping. You can see the distance between the two orbits that you can potentially fit two other orbits. That's hypertelorism from the FMF website here. So you can see there. Then the follow-up should be standard, and antenatal care should be adjusted according to the risks of the condition. Through the syndromic approach, we should try to figure out which syndrome is responsible. Standard obstetric care and delivery, then if isolated, it is generally good in terms of the prognosis, but in severe cases, the cosmetic implications are important. There might be impaired stereoscopic binocular vision, and in syndromic association, the prognosis is normally poor with a high risk of neurodevelopmental delay. There is no increased risk of recurrence. Hypotelorism is the opposite of hypertelorism, occurs in about 1 in 20,000 births. This is a decrease in the orbital diameter or distance of which is below the 50%, or you cannot fit another orbit in between. That's a gross kind of assessment. It occurs as part of the midline migration defects, together with holoprosencephaly. I think a number of you have come across cases of holoprosencephaly in the unit. The degree of hypotelorism can be so severe so that we end up with cyclopia. We've seen a number of these cases, and chromosome abnormalities, mimic trisomy 13, are found in about 50% of the cases. Genetic syndromes are very frequent, and the most common is Micrognathia syndrome, which is an autosomal recessive. It's a lethal condition characterized by hospital encephalocele, multicystic kidneys, and post-axial polydactyly. This is why it is important to do the syndromic approach so that we can be familiar with these syndromes, like Micrognathia. This is an example of hypotelorism. We are trying to image the eyes, and you see these very two close eyes, which is almost looking like a cyclopia. This is severe hypotelorism. If it is part of trisomy 13, it is lethal, and the normal karyotype, there is a high risk of neurodevelopmental delay, depending on the degree of holoprosencephaly. That is, remember, the lobar, the alobar and semilobar are lethal. It is the lobar holoprosencephaly that is a variable outcome. But if it is a lobar and semilobar, then you know it's a lethal condition. The alobar and semilobar holoprosencephaly. Recurrence risk is isolated. If isolated, there is no increased recurrence risk. Part of trisomy 13 is 1%. Part of an autosomal recessive condition like Micrognathia, the risk is 25%. Case should be standard, and karyotype should be offered. Of course, neurosonography should be done. Standard obstetric care and delivery. If it is part of trisomy 13, then they should be offered termination of pregnancy as an option. Micrognathia occurs in about 1 in 1,500. This is a subjective finding of a prominent upper lip and a receding chin in the mid-sagittal view of the face. This finding may be due to micrognathia or retrognathia, which is backward displacement of the mandible. So the difference between the two, when you look at the babies, of course, it's very difficult to know which one is which. But I believe on gross examination, this is where this decision can be made to say, do we have a micrognathia, a short mandible, or we have a retrognathia, which is more of a backward displacement of the mandible. Severe micrognathia is associated with polydamnios due to glossosis. Glossosis means a protrusion of the tongue outside. So when you are doing the image of the profile, make sure you check to make sure the tongue is not protruding outside, because in the presence of a small chin, the tongue will appear like too big for the mouth and it will obstruct the oral cavity. The chromosome abnormalities here, we have trisomy 18 and triploidy, which are found in about 30% of the cases. Then we have the other genetic syndromes, such as Pierre-Robin anomaly. I've already described this, Treacher-Collins syndrome, and the autocephaly. I've already described these syndromes, and yeah, so I'll move on. I think the team can read this when you guys on YouTube or lecture which I sent, the slides I sent. So in terms of examination, just a detailed ultrasound scan examination and invasive testing for karyotyping and chromosome array. Then ultrasound scans every 4 weeks, monitor growth and amniotic fluid. Then delivery, hospital with intensive care, and should be around 38 weeks. Then induction of labor, aiming for vaginal delivery, and the pediatrician should be present in the delivery room and be prepared to intubate the neonate. Then the prognosis, neonatal mortality was more than 80% due to the associated abnormalities. In Pierre-Robin, anomalized survival is good, and recurrence, no increased recurrence of increased recurrence if it is isolated, and if part of trisomy is 1%, part of genetic syndrome is 25 to 50%. So ruling out association is very important. Nose abnormalities. Why did I put a picture of microphthalmia there? Micrognathia, I'm sorry. I think we have images. I don't know why I didn't put it. Then nose anomalies. These occur about 1 in 10,000. It is a spectrum of midline abnormalities of the nose in association with holoprosencephaly. So with holoprosencephaly and nasal defects, we may get arynia. Arynia is a complete absence of the nasal structure, and sometimes you may get a proboscis, which is a soft tissue appendage projecting from just below the forehead, and we may get a single nostril, which is usually central. Chromosome abnormalities such as trisomy 13 are found in about 40% of the cases, and the holoprosencephaly is found in all cases, and the genetic syndromes are found in about 20%. This is an example of a proboscis right here. So we can see a proboscis right here, and on top we can see that there's absent noise. Arynia, and more of a cyclopia with 2 orbits. This is a case of one of our cases which had holoprosencephaly. So you can see the kind of facial abnormalities. And this is the ultrasound scan appearance. I'm not sure if that was the same case there, but this is another case of holoprosencephaly. You can see the proboscis again here, just below the forehead, and the arynia absence of the nose, and more of a flat face. That's what we mean by flat face. Everything is level here. So karyotyping is recommended due to the associated chromosome abnormalities. Standard obstetric care. Remember, offering termination of pregnancy is an option here because of the lethality of holoprosencephaly. So prognosis is very poor if due to the associated holoprosencephaly and chromosome abnormalities. Then the recurrence risk, if isolated, is about 6%. Part of trisomy is about 1%, and part of genetic syndromes, 25 to 50%. Just to show you a flat face here. There's a flat face, then we have hypoplastic nasal bone. You can see a very flat face. It was one of the babies. I'm not sure what syndrome was it, the trisomy 18 or what, but it was one of the babies we looked after. It's the end. It's done. Yeah, so the facial abnormalities are done. I think we've covered the most common. I would say we're exhaustive in terms of looking at the facial defects, but these are the most commonest defects that we do encounter in our line of work.